Welcome everyone to Office Hours, and I just want to thank you for joining us today. I'm Stuart Newsom, serving as VP of RCM Insights here at Infinix, as well as your host. And I will be flying solo for this session. So no guest, but hopefully some valuable knowledge will be shared with you. So I want to spend our time together walking through something that is reshaping the revenue cycle in ways that are both subtle and extremely consequential. Payers are increasingly relying on AI to evaluate claims, interpret documentation, and identify potential payment issues faster than humans ever could. These decisions are happening quietly and often before anyone at the hospital side even realizes the claim has been touched. Now, that shift alone has major implications for how we prepare, how we protect our revenue, and even how we build defensibility into the day-to-day operations. So today's session, which is titled Defending Revenue When Payers Use AI, is meant to provide clarity, not alarm, direction, not theory. What I want to do is pull back the curtain on what payer AI is actually doing and why even correct claims are getting flagged, how internal processes shape external outcomes, and what hospitals can do today to become more resilient against both prepayment denials and post-payment recoupment activity. Now, as usual, we'll end with a Q&A, so please leave your questions in the Q&A box as we go along, and I'll answer them to the best of my ability when we at the end of what I have to say today. And also, I welcome any comments. Always welcome any comments. If you have any insights on this subject, please share them as well, and I can share them with the rest of the audience. So my hope is that you walk away not only understanding what's happening, but also feeling more in control of how to respond to it. To begin, we need to acknowledge the landscape that we're working in. Now, for decades, payers have used automation, mostly rules-based logic, to flag issues on claims. Those systems weren't intelligent. They reacted only when certain conditions were met. A modifier was missing, a code pair wasn't permissible, or a field was incomplete. Maybe the denial might be automatically generated because of those factors. Now, human review may have stepped in only when something required interpretation, maybe some clarification, perhaps some deeper evaluation based on the claim that those parameters couldn't catch. Those days are gone. Today's payer systems are powered by generative and agentic AI models that operate on principles fundamentally different from the rules and edits of the past. So AI models do not treat claims the way human reviewers do. They do not begin by asking, is this correct? Instead, they basically ask the question, does this match the pattern? And that's the key word, is pattern. So I'm going to resonate that throughout this discussion. And that distinction, which is correctness versus conformity, is at the heart of why hospitals are seeing denials and audit triggers that feel completely disconnected from the clinical and coding accuracy of what was submitted and what we've been used to in the past. Now, before we go any further, I want to clearly separate two concepts because this distinction is critical as we move through the rest of this conversation. Now, many of you are going to know this. You're going to say, Stuart, this is obvious. I already know all this, but I think it's important to lay it out. Now, first of all, a claim, we're going to talk about a claim, is structured data. It's codes, it's dates, it's modifiers, it's units, it's NPI information, diagnosis sequencing, and the metadata that surrounds all of these elements. Claims do not contain the clinical narrative. They contain the coded representation of the encounter. I've always said coding is the language that payers use to determine what happened at that encounter level. Now, documentation is the other side. And documentation, on the other hand, is the narrative record. It's the physician's description of the patient's condition, the reasoning behind their decisions, the operative report language. Maybe it's in the radiologist phrasing and the supporting clinical details. So documentation is where medical stories are told, but claims are where those stories are abstracted. Now, AI interacts with both, but in different ways. It scans claims first because they are structured and efficient to evaluate. That's the way they were designed. It interprets documentation second, but only when documentation is pulled into the review process. Now, it could be in a prepayment review where it requests documentation when something about the claim data deviates from the expected patterns. It could be in a post-payment review where it pulls documentation after analyzing clusters of already paid claims for statistical anomalies. And that's where today's challenges really begin. When a claim is submitted, the AI immediately evaluates its structure. It looks at whether the diagnosis procedure relationships align with the expected patterns. It looks at whether the timing of documentation and service dates are typical. It looks at whether this provider usually submits claims like this or whether something appears unusual. It looks at the sequencing, the volume, the utilization trends, and it compares all of this not only to the provider's historical behavior, but the behavior of all the providers in similar specialties using the same CPT codes, as well as any diagnosis and treatments. Now, AI is not looking for accuracy in the human sense. It's evaluating familiarity. Now, when a claim fits the model's learned patterns, it moves smoothly. But when something deviates from those patterns, even if it's a clinical appropriate pattern, the AI pauses, and that pause often becomes a denial, a documentation request, maybe a transfer to prepayment review. AI does evaluate clinical data points, but only through the statistical tendencies it has been trained on. It does not understand clinical correctness the way a physician or a coder does. It estimates likelihood based on what it has been seen before. What are those patterns before? So when a claim or its supporting documentation aligns with those learned patterns, the AI interprets it as accurate enough and then proceeds. And when it falls outside those patterns, that unfamiliarity itself is treated as risk. And that's why clinically appropriate claims can still trigger automated actions because it's not within those patterns. So let me give you a concrete example to illustrate what this really looks like in practice, because this is where hospitals start to feel blindsided. A hospital began noticing that spinal fusion cases were suddenly getting flagged at higher rates. They did what any hospital would do. They reviewed the documentation. They even reviewed the coding. They looked for any inconsistency of patterns or errors. Everything checked out. Nothing was clinically incorrect. Nothing was coded improperly. The operative reports and the imaging were all accurate. But what they eventually discovered was that there was one radiologist who described a particular degenerative finding using slightly different phrasing than other radiologists at the same organization and different phrasing than what the payer AI had been trained to expect. Now, his description was clinically accurate, but because his language didn't match the model's familiar patterns, right, the AI interpreted it as a potential anomaly. And that alone triggered the entire series of reviews. So this was not an error. This was not a compliance lap. This was simply a difference in phrasing. But that difference in an AI system is risk, and risk becomes a flag. So this brings us to one of the most important shifts hospitals must reckon with today. Clinicians are no longer documenting solely for other clinicians. Now, for years, compliance teams have tried to reinforce the documentation must also stand up in front of a judge. Now we have a third audience, and that is AI agents that interpret documentation according to statistical tendencies rather than clinical nuance. Documentation must be accurate, but it also must be interpretable. And that reality is reshaping the entire landscape of defensibility. Now, beyond documentation variances, AI models rely heavily on something hospitals don't always think about, and that is metadata continuity. AI models are highly sensitive to whether information is stored consistently, whether the timestamps follow expected sequences, whether supporting records appear in the systems that the AI expects to see them, and whether version control exists. Now, if documentation is stored across multiple systems without unified metadata, or if addendums are made after expected timeframes, or maybe even attachments aren't labeled consistently, the AI interprets these gaps as missing information, even when the information is truly present. Fragmentation becomes absence, and absence becomes risk. Now, another consistent issue is timing. AI evaluates how long it took for documentation to be completed, when signatures were applied, when addendums were made, and whether the submission timeline matches what the system considers normal. Humans understand context. They know that a surgeon may dictate their operative note the next day because they finished late in the evening. But AI does not interpret circumstances, it interprets deviation, and deviation becomes a flag. And that brings us to the internal vulnerabilities that make payer AI more effective at denying claims. First, many hospitals struggle to produce complete audit trails. These audit trails, obviously, for documentation. Now, they cannot always show when a note was created, how it evolved, whether supporting documentation was linked properly, or which version existed at the time of the claim submission. Now, there are some institutions and facilities that do some of these well, but not all of them consistently. So without an audit trail, the hospital cannot reconstruct the record in a way that defends against an AI-driven interpretation. In the AI's view, accurate or not, becomes the assumed truth. And then second, documentation inconsistency creates noise. Clinicians all have their own phrasing, habits, even preferred structures, and that's normal. But AI reads variation differently. Variation looks like unpredictability, and unpredictability looks like risk. Now, again, this doesn't mean that clinicians should write like robots. It means that structure and clarity of documentation must be consistent enough that an AI system does not misinterpret individual differences as anomalies. And then third, there's siloed workflows, almost guaranteed misunderstanding between what the hospital thinks the AI sees and what the AI actually sees. AI has access to the entire claim and is related documentation. Now, I should preface that and correct that. It's really the AI, the payer AI has access because payers have all the data. They've been accumulating data for years. And now they just have the means of using this payer AI to crunch and accelerate that data however they please. And at least to the extent that documentation is actually linked there. But internally, hospitals often divide elements of the encounter across separate systems, separate teams, separate workflows. We all have been talking about interoperability for as long as I can remember, but still there seems to be some separation and silos that exist. Now, when internal teams don't have unified visibility, they cannot anticipate what the payer sees as a complete picture. And then fourth, internal automation can introduce subtle artifacts. These are automated template phrasing, pre-filled fields, inconsistent terminology suggestions, or maybe even variable sequencing. Now, these automated elements may not be problematic clinically, but they can appear unusual to an AI model evaluating pattern integrity. And again, pattern integrity is so important to an AI model, especially payer AIs. Now, when internal automation is not monitored, it can inadvertently introduce inconsistencies that a payer AI misinterprets. Now that we've looked at prepayment activity, we need to talk about something equally significant, and that's payers using AI to identify recoupment opportunities through post-payment review. Now, this is an area that has escalated dramatically. Once claims are paid, many hospitals assume those payments are final unless an issue is identified through a traditional audit. And we all know about those traditional audits. But payers today are running large machine learning models against years of paid claims to detect patterns that were previously unnoticed. These models look for clusters of similar claims that deviate from the expected norms, not always clinical, but structural. Once those patterns are identified, the payer initiates some post-payment review. Typically, a letter arrives. The language is often very vague, something like patterns were identified in previously submitted claims, or it's most likely documentation does not support payment for the identified services. What triggered the review was not a human finding an error, it was an AI detecting a pattern deviation. So here's where documentation becomes absolutely critical. In prepayment review, documentation helps justify the service. In post-payment review, documentation must prove that the record at the time of submission was complete, consistent, and accurately represented. If the record cannot be reconstructed, if documents are missing, scattered, or have unclear version histories, then the hospital loses the ability to defend that payment. And in many cases, they lose the appeal and have to send the money back. Now, a large health system recently faced a substantial recoupment because imaging documentation lived in separate platforms with incomplete metadata connections. The documentation really existed, but because the hospital could not reproduce how the payer AI saw the record, they could not defend the payment. Now, in another instance, more than $1 million was recouped because the payer interpreted missing metadata as missing clinical evidence, even though the clinical evidence itself was never actually missing. So the hospital simply couldn't reconstruct the original record. And this is where the responsibility shifts back to the hospitals. This also applies to any providers too in the ambulatory space. But it wasn't because that provider did anything wrong, but because defensibility now depends on preparing for how AI interprets the record, not how a human understands it. So given all this, what can hospitals actually do? To build defensibility in an AI-driven payer environment, I want to frame the response around four pillars. It's really four areas, if you will, that must be strengthened if organizations want to be to withstand both those pre and post payment scrutinies. So the first pillar is data governance, but not in the broad IT sense. Here, data governance means the ability to reconstruct the record exactly as it existed at the time of submission. This requires unified metadata standards, consistent document storage, complete audit trails, and clear linkage between documentation and the claim. If you cannot reconstruct the record, you cannot defend it. It's that simple. The second pillar is infrastructure readiness. This is not about whether your system can ingest denial codes. Many platforms can do that. But infrastructure readiness means whether you can actually ingest denial signals in a structured, interpretable way, whether you can identify patterns, threshold shifts, and clusters, just like the payer AI can. So whether you can actually correlate denials to documentation or workflow behaviors, and whether you can actually surface payer AI behavior early enough to act on it. So this level of readiness gives hospitals the ability to detect changes in payer behavior before those changes escalate into financial risk. Now, the third pillar is AI monitoring. Now, though it's important, I'm not really talking about monitoring your internal AI tools here. What I'm meaning here is monitoring external AI behavior, specifically payer behavior. So it involves recognizing when certain documentation phrasing begins to trigger reviews, when certain services suddenly experience increased prepayment delays, perhaps when recruitment activity clusters around particular codes or clinicians, and when the AI appears to have shifted its thresholds. Now, monitoring payer AI behavior is how hospitals regain situational awareness. And then the fourth pillar and last pillar is cross-functional governance, anchored by accountability. And this is one of the most important. Governance is only works when someone clearly owns it, not when it's spread across teams with no central responsibility. Documentation standards, audit trail practices, metadata policies, response workflows, and ongoing communication between clinical documentation, HIM, compliance, IT, revenue cycle. I think you get the picture. They all must be unified under a single framework where ownership is clear. Without accountability, gaps remain invisible until they become expensive. So that's it. That's a quick down and dirty summary, so to speak, or a snippet of a growing problem of payer AI capabilities. And I hope you gained some insights into this issue. You can obviously reach out to us. We can give you more information, and I'll be happy to discuss it in more details at a more granular level. But again, this was just very, very, very high end for you. But before we close, I do want to go ahead and move into our Q&A portion. So I just want to look over some of the questions that are coming in, and if there are a few of them here, I think that may actually resonate with you. So as I look at down here and see if there's any questions we have, I don't really see. Yeah, here's one that's coming in now. Let me try and pull it up. I can remember how to open up the Q&A box. So the first question here states, if we don't know how payer AI is affecting us, where do we even start? Okay, that's a fantastic question. Starting at the right place is always matter. It's probably the most foundational one for that reason. So the place to start is not necessarily with new technology or new workflows. I know that's probably not the response people were expecting. I know we all flood to maybe some new gadget, some new shiny object, some new technology that's going to solve the problem for us. And I can tell you right now, there's a lot of great systems out there. But AI in and of itself is not going to solve everything. That's why here at Infinix, we take a tech-enabled services approach where we look at it holistically, trying to solve the problem by any means necessary, whether it be through AI agents, whether it be through the human agents that we have, through the expertise that we have, with security involved and everything to make sure that your data is not only protected, but you're actually receiving the appropriate revenue. So, but the key here, to answer your question, the place to start would be traceability. And that means understanding whether you can actually recreate the record that the payer's AI evaluated. I kind of talked about this earlier. So it's not just the documentation and not just the claim, but it's the entire package. Again, if you remember, I talked about metadata. I talked about timing. I talked about audit trails, version control, and does does the version still exist at the moment you submitted it? One of the things that we're learning is that defensibility, and that's key. You have to defend what you've done there. Doesn't come from the sophistication of your tools. It comes from your ability to show your work. You remember in school, we had to show our work, right? Even though we knew the answer and we could figure it out in our head, we still had to show our work. And the same applies here. You have to prove it. If you can't reconstruct the encounter exactly as it existed at the time of the payer made its decision, meaning physician's documentation, signature timing, imaging evidence, so forth, any prioritization proof, then you have something solid to stand on. The moment you lose the ability to reproduce that record with confidence, you lose leverage. So I would encourage organizations to take a sample of recent denials or post-payment requests and actually walk them backwards, kind of recreate the scene of the crime, so to be. Not by memory, but what do you think you think the system should have seen, what the AI payer should have seen? You know, by pulling up the documents, the timestamps, the metadata, the workflow path, exactly as the payer would have seen them. So what you will usually find isn't a clinical issue. It's a visibility issue. It's transparency. It's traceability. Something lives in another system. Something isn't linked right. Maybe the signature timestamp doesn't match the expected pattern. Maybe a document was scanned in with missing metadata. Perhaps an addendum. I've heard this before, believe it or not. An addendum overwrote an original note without preserving version history. I don't know if that's ever happened to any of you, but that's not a good thing. So these are not clinical failures. These are defensible failures. And defensibility is the starting point. So once you understand where visibility breaks down, even slightly, you start closing those gaps. And the good news is that most of these fixes don't require new technology. They require alignment, consistency, and intentional coordination, kind of going back to the four pillars that I mentioned earlier. So the first step is not necessarily go fix the payer. The payer is using AI whether we like it or not. The first step is let's make sure we can see what the payer AI sees, because that visibility is what gives you the ability to respond effectively. So I'm going to look, there's another question that we have here. Um, how do we get clinicians to document consistently without making them feel they're writing for payers? Yeah, that's always been a time and a trusted method of, do you write from a clinical perspective or are you just trying to get the claim paid? So that's a great question, but it's also a very sensitive one because clinicians really don't want to feel controlled, and they shouldn't. They also don't want to feel like they're being asked to document for reimbursement instead of patient care. And frankly, none of us really want that, right? The framing matters enormously here, though. Clinicians should never be told to write for the payer. They should be told to write in a way that protects their clinical intent. And again, keyword there is protecting their clinical intent, their clinical judgment, not from misinterpretation. And AI misinterpretation is becoming a real issue, not because clinicians are wrong, but because AI doesn't really really kind of look at that documentation from the standpoint the way a medical professional does. And I'm including medical professionals that are, PAs, RNs, DOs, MDs, and even it spreads to coders as well. It reads patterns, it reads structure, it reads sequencing, it reads phrasing. So when documentation varies widely, which is normal in human communication, but confusing to AI, the model might interpret that variation as inconsistency or incompleteness. And that misinterpretation can lead to delayed care, obviously clinical documentation requests, denials, everything that you don't want to escalate. So when clinicians understand that the goal is not conformity for the payer's sake, but clarity to prevent their clinical judgment from being overridden by an automated system, then conversations shift. I often position it this way. Clinicians are and always have been documenting for three audiences. I kind of alluded to this earlier, I know, but I'm going to repeat it again. So first, they document for other clinicians. When clinicians read medical records, they know exactly what the other clinician means. That's the clinical continuity piece. Second, whether they like it or not, they have to document for judges and appeals bodies. They have to make sure there's compliance built into the system, because documentation often becomes a part of legal records when a case escalates. And now For better or for worse, they are documenting for AI agents whose interpretation depends on patterns rather than reasoning. So the goal isn't to strip individuality. The goal is to avoid accidental ambiguity. And I'm intentionally saying accidental. Clinicians appreciate this when they see how denial or recoupment can stem from something as small as phrasing variations, not necessarily a clinical area. Now, once clinicians understand that documentation consistency protects their patients, it also protects what they're doing, their care plan, it protects their medical judgment. They're much more open to small refinements so that will improve clarity without compromising their professional voice. So it's not just about, hey, this is going to get you paid more. It's actually going to be or just clearly articulate, what you're doing for the patient, not just for another clinician to understand, but for AI to understand as well. So I'm looking around, see if we have any other questions. I don't see any others. So looks like we are almost on time here. Um, as we close today, I just want to emphasize one thing. Payer AI is not slowing down. If anything, it's accelerating, both before and after payments. This is not going to go away. It's only going to get worse if you want to look at it that way. But hospitals are not powerless. When your documentation is consistent, your audit trails complete, your metadata aligned, your workflows integrated, and your government's accountable, you are no longer reacting to payer decisions, you are preparing for them. And preparation is what gives hospitals control. So I want to thank you for joining me today, hanging with me as I'm flying solo once again. And I look forward to continuing this conversation during our next office hours. So please be on the lookout for a link. Be sure to register. And don't forget to visit our website. We have lots of articles, case studies, and additional information that could be of great benefit to you. We hope to hear from you.